For having me again for this very wonderful session. And I understand we do not have a case presentation today, so that actually gives me more time to interact with participants, which I really love to do. So not wasting any more time, I would like to just share my screen. Yeah, is this can you see
Ye-
my screen now?
Yes, ma'am. Yes, ma'am.
So I'll just put it on a presentation mode. So we are talking about ethics in palliative care, medical ethics in palliative care, which is which is extremely important because uh, ethics are the ground rules that binds all healthcare workers together, and uh, these I can't say these are rules, but these are certain guidelines, certain a kind of a framework within which we as healthcare providers are protected. You know, so uh, these are very very important in our professional lives, as well as these things actually are going to impact on our personal lives also. The way we behave with our colleagues, the way we conduct ourselves in our professional workplace, whether it is a administrative work or the work that relates to our patients. So everything is actually, we are all bounded, uh, to certain rules and regulations. And those, in a nutshell, would actually give us as an essence of the medical ethics in palliative care. Otherwise, in general, medical ethics is huge, it's a vast subject in itself, and you can keep on learning, find out your own ways and means to grab, signals or, information regarding the ethical principles that govern us in a professional manner. So basically, we are going to see the definition of medical ethics, the four cardinal principles that are important. You can say these are the four pillars. And one thing that actually boils down when we talk about basically about palliative care is euthanasia, because that is what I would like to um, kind of link myself when I practice palliative care, because as I have always said, and I still am aware myself that 90% of my patients generally are in an end of life stage. I would want them to come to me in a very earlier stage, but then unfortunately, I get patients when they are almost in the stage of end of life care. And that is a stage where people really do not want to see their loved ones suffering. And then so much of peer pressures, so much of writings, so much of blogs about um, you know what how to give their loved ones a relief from such suffering. And the only answer to that, that they actually justify, is euthanasia. There have been many movies that have been made. There are countries that practice euthanasia, but then, being a palliative care physician, I would not really want to euthanize my patients. whether they are at the end of life stage or whether they are wanting it themselves. So it's a dicey situation. 45 to 1 hour may not be ideal time to explain everything, but then I'll try to give you in a nutshell the importance of medical ethics, the cardinal principles, and how in palliative care situations we can apply these principles and then go to euthanasia. So basically, ethics by definition are, you know, are the moral code of behavior, the way we behave with the other individual, or whether that individual is a colleague or that individual is a patient or a caregiver, or our behavior towards the organization as a whole, our behavior towards ourselves, because we also talk to ourselves, we also imagine ourselves as a different individual when we are in a situation. Okay. So ethical principles basically are a set of principles which are on in a moral account, should function as an analytical framework that expresses the general values underlying the common morality. So the the definition as such gives you, how to work or how to conduct yourself. What are the things that you should not do, what are the things that is permitted for you to do. Okay, so basically an analysis of how you are going to work, how you are going to provide solutions, how you are going to provide treatment options. Okay, so but then there would be the basic principle of more moral values. Okay, um, maybe when we were children, when we were in the school, you know uh, we were taught about moral values. Okay, so if you think about that basic thing, you would actually get a picture of what would be a moral account, what would be something which is morally, uh, you know, mm, okay for people to accept and you to provide. So this particular principle, ethical principle definition, was coined by Bucamp and Childress many, many, many years ago. And, there have been so much of research um, uh, on how to actually, implement this definition while we work. Okay. And talking about palliative care, uh, it's a huge dicey situation. Basically, when we are facing end of life care situation with our patients, and of course, their caregivers and families. So, ethics of palliative care are simply the same as those of medicine in general. Mm, to be very honest, when I was a student of medicine, very little was taught about ethics. Whatever I learned or my contemporaries learned, my classmates and my seniors, juniors, we all learned through observing our seniors, our professors in the world, the way they behave, the way they talk. And to be very frank, we were very confused because one would behave in a different manner one would suggest a different solution, and on the other hand, a different person, or maybe a registrar or a professor would behave or give a solution in a completely different manner. So nobody taught us about ethics at that point of time. So when we started practicing palliative care, that is the point where we knew that the ethical principles uh, you know can be applied to such vast area of work. And palliative care as such is a place where you can itemize, you can permute and combine so many things together and find out the best possible way. So having said this, the doctors generally have a dual responsibility to preserve life as well as to relieve suffering. Uh, but having said this, when as palliative care physicians, we are faced with end of life care, and we are, tasked with relief of suffering. Unfortunately, we have actually seen that um, the relief of suffering becomes more important uh, as we exhaust the preservation of life for our patients. Okay, so that is an important learning in ethics of palliative care, where we have to understand that uh, preservation of life is perhaps has now taken a back seat, and the relief of suffering is of prime importance. So I'm sure you all know about the four cardinal principles of medical ethics, but then again, I would like to, just revisit them. They are patient autonomy, beneficence, the principle of non-maleficence, and justice. So basically, patient autonomy means, what does the patient want? Does the family understand the preferences of the patient? Beneficence would mean that whatever we do, is it actually going to benefit the patient at that particular point of time of his or her disease? Non-maleficence will surely, give us the question of whether our actions are going to harm the patient or not. Okay, and if it is harming the patient, then we are not actually following the principle of non-maleficence. And then justice is, of course, uh, fair utilization and allocation of resources. So we're going one by one into them, the all these principles. But then why do we generally talk about ethical principles here in palliative care, or for that matter, you know, in medicine in general? Why do we need to follow principles, ethical principles? So, uh, certain situations would actually confuse us, because we are also human beings, and we are faced with certain situations where we really don't know what to do. It's like really don't know what to do next. How do we proceed, and those particular situations are known as the situation of dilemma, where we see that both the roads are right, but one of the road leads us to a different destination, and the other one would lead us to another one. So these kind of situations are known as ethical dilemmas. And basically, uh, ethical dilemma is a conflict of moral principles. You know that both the principles are right. This road is the correct one, but then you also realize that the other one is correct again. So how do I choose between the two? Okay. So there is a conflict of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. So basically, it's a confusional state. It's a problematic state where you want to justify one, you do that, and then you see that you are actually compromising on the other. So ethical dilemmas are generally those situations where we have to take, certain decisions which which will not really do any harm to our patients, which will be justified at that point of time. And later on, when you retrospectively look at your decisions also, you must not, think that, oh my God, what did I do? So basically, ethical principles would would bring us out of such dilemmas and give us a framework and analysis where we are able to justify why we took one particular decision for such a patient. So I'm just going to give you an example. Okay. So here, since there is no case discussion, I'm just going slow, and I would want, all of you to give me inputs on your chat box, or you can also unmute and talk so that, this becomes a little more interactive. So this is a patient, as you can see in the picture. Uh, and this patient has a jaw tumor, and there's a fistula on the jaw. Okay, it's called an orocutaneous fistula. It's definitely because of the cancer. Now, this person is an elderly person and he's in extreme pain. Okay, uh, there has been certain evaluations of the patient, and the doctor has found out that there is no distant metastasis at all. Okay, and that means that, this particular fistula and the tumor is partially resectable, and this patient can have a good life after a resection and a further, curative treatment. Now, for this thing to start off, the patient needs to be on an NG tube or a nasogastric tube, so that, further treatment can be started, further evaluation can be done. Patient simply refuses NG tube insertion. So the oncologist actually sends this patient to you for, further interaction. Or so what is our stand as palliative care physicians? What would you do? What is the next step that you would want to do? So can I have some small uh, inputs from your side? You can talk, or you can just simply put in your responses in the chat box.
There are a few responses in the chat box.
Okay, so all right. So Dr. Okay. Age of the patient. Ask him what are his worries regarding the NG tube. Very good. Inquire the reason why the patient is against the NGT. Yes. Explain the need and suggest alternatives like PEG. Okay. Counseling of the patient and the family is important. Okay. Explain the condition, provide benefits of NG tube, ask the reason for refusal. Okay. What he wants for pain relief. Okay. All right. So we do have very good responses, and they are all correct. Yeah. If there is a phobia, then remove it definitely. Counseling can be then explain the pros and cons. Yes, absolutely. So we all are and in the same page now. So basically, you see, uh, sorry. So basically, this person, should get a good kind of interactive counseling where we would actually want him to uh, take out all his fears. The phobia that somebody had talked about. So basically, this is a dilemma between doing good and the choice of the patient. Now, the choice of the patient is that I don't really want the NG tube. This is my autonomy, and I don't want an NG tube. Okay. And then, secondly, the the question of doing good or the ethical principle of beneficence. We know that if we put him on a NG tube, it's definitely going to benefit him. Okay. But if we don't uh, uh, listen to what the patient has to say, or we override his choice of, not getting the NG tube, then we are compromising on the patient autonomy also. So now the next thing that we will have to understand is that what is exactly is patient autonomy? Why do we, give so much of importance to patient autonomy? Basically, when we are talking about patient autonomy, we are wanting the patient to be involved, completely involved in decision making. Patient, this is my body. I am responsible for everything that is going to have, an impact on my body. So I have the right to be involved in my decisions. Okay. If I think that I don't want the NG tube for whatever reason, I simply don't want it. You just cannot come and restrain me and put an NG tube like that. I will not allow it. So we as medical practitioners, we as doctors, we as nurses and paramedics, we have to give that particular importance. That is number one. So the patient will have the right to dignity, will have the right to privacy. The patient will have the right to confidentiality. Secondly, the patient will have the right for getting the right kind of information. Okay. It is not just information. It is his right to have the right kind of information. And this particular right information is actually the counseling part that we are talking about. Because when we start with counseling, we are giving as much as information regarding the procedure, regarding the disease, or the all the answers to the queries of the patient. Okay. And that is the reason why we are giving him the right kind of information. And when I say right information, right kind of information, it has to be understood by the patient. If you keep on just lecturing the patient and you really don't know whether the patient has understood that information or not, has been able to process it as you want him to process, I think there is no point talking to the patient or counseling the patient. It cannot be, one way information sharing. It has to be both ways. The patient has to ask questions. When I'll give a small example on this particular thing because it's very important for us to understand. When we, in our MBBS days, when we really didn't have PowerPoint presentations and all, but still we had to, give a case presentation. Uh, all we wanted is to go to the stage and vomit in front of the class. I have prepared my case. This is it. Whatever, I have completed my job. Okay. Why was that? Because it was a fear that we have to talk in front of everybody. But then, uh, what our professors used to tell us is that if nobody has questioned you, that means they have not understood what you have said. It is the same thing that applies here. If you are giving some kind of information to the patient, there has to be questions from the patient side. And when you see that there is no question from the patient side, 90% chance is that the patient has not understood. So start all over again. Give him or her the chance to bring out questions. Those questions may be irrelevant, but then your wisdom is to take that signal of where the patient has not understood what you have tried to convey, and then give that patient the right kind of information so that he knows what lies ahead, and he can decide on the uh, process, and I mean he can decide on whether to go for that or not. Okay. The thirdly, patient autonomy also involves the right to make decisions. If you have the right kind of information, you can take better decisions, the best decision, in fact. And we as caregivers, we are also part of the caregiving committee of the patient. And we can actually give the patient the proper power to take the best decision for himself. And then last but not the least, patient autonomy also means that the treatment decision has to come as an informed choice of the patient. The words that, okay, doctor, I think I'm ready to go for the procedure. This particular sentence has to come from the patient himself. Okay. So this is what patient autonomy means, and in every step of your professional career, whether you are in palliative or not, this particular principle needs to be followed. If you follow patient autonomy, you will save yourself from a lot of problems. You'll have good communication skills. You will have uh, a better rapport with the patient and the patient family, and you can see that the importance uh, of getting an attention has actually shifted from the patient to you. People will start listening to you. So you give importance to patient autonomy, and in return, get that importance for yourself too. Okay. So now, for the next for this particular patient where he is refusing. Now, for him, the autonomy means that if the patient is refusing, you'll have to take a informed refusal. An informed refusal is for yourself. I am taking the refusal of the patient uh, on the grounds of all these four things. Number one, as we discussed, check the understanding. Has the patient really understood what an NG tube is going to do? How the process is going to be done? Maybe the patient doesn't know he thinks that the NG tube is going to be inserted from the nostrils and it's straight away going to hurt his spinal cord. Okay? He doesn't know about the anatomy of the body. However, you tell him, uh, I'll tell you one of my stories here also. When I was in the eighth standard, my ears were not pricked, I didn't have the holes here. That's because I was fearful of the needle. I knew that the needle would be actually piercing my skin through and through, and that was not acceptable to me. So every time my father used to take me to the hospital to get my ears pierced, I would run away. I would just disappear from, they wouldn't find me for the rest of the day. So I thought it's going to bleed. I will have to get an anesthesia until and unless I get anesthesia, I won't be letting anybody touch my ears also. Okay. It is same for this patient. It might be, one of the reasons that he is thinking that this long tube is actually going through my nose and it's going to hurt my spinal cord. So we have to check the understanding. What is he understand? Does he know that this is a normal thing? It will be going through a normal passage to the stomach. Does he know the anatomy? Can you actually take the effort of drawing the passage for this particular tube so that it actually gives him a visualization that it's the stomach that is it's going to end there, and whatever food he takes, it's all going to end up in the stomach. It's not going to hurt at all. Okay, there might be some kind of disturbances for a few days, adjusting to the NG tube and all these things, check the understanding. Secondly, explore the reasons for his fear. As I said, he might be thinking that this is actually going to the spinal cord. He might also think that it's going up to the brain. He might also think that I'm going to bleed to death. So explore the reasons. He might also think that no, it's going to be very, very painful and I'm not letting anybody touch my nose at all. Okay. Once you know the understanding and you have explored the reasons, then you place your cards for counseling. Give him the right kind of information. Take out all his fears. Okay. So it's nothing but good communication skills, nothing but, instilling that particular, goodwill into the patient, that once this is done, you will be getting rid of this particular fistula, of this particular cancer. Your life is going to be prolonged for such a long time. You can actually lead a normal life. Okay. And from all these things also, all three of these things taken together also, you are like, you have given it your best, you have tried to explain everything, but then still the patient is refusing. Then you must actually agree that the patient may not want an NG tube, but still you support the patient. Okay. Now, when I say support the patient, I mean that you keep the door open for next few days or maybe few weeks also. Because in my very short career of these 15 to 20 years, what I have seen is that when I keep my door open, when I say it's okay, fine, if you really don't want that, I'm not going to forcefully do it for you. But then, I'm always there for you. If you have any other questions, please come tomorrow, day after tomorrow, whenever you wish. Okay. And at one point of time in the future, take my words for granted that the patient is actually going to come back to you, because this particular ulcer is going to increase in size, increasing his pain, increasing his agony, and he might as well think about this particular doctor. Oh my God, she has taken so much of effort to make me understand. She had given, at least 1 hour to talk to me about this. Maybe I can just think of taking her advice. So, so autonomy for this patient is taking an informed refusal. And at the end of it, if the patient agrees, well and good. If the patient doesn't agree also, be with the patient, support with the patient with the decision that he has taken. Okay. Any questions on this particular part? So we'll move on to the next. Now, this is a similar case. Okay. This is a 20-year-old boy. He has an osteosarcoma of the lower end of the femur. This tumor has now grown so big that he's also got multiple metastases in his lungs. And, as osteosarcoma, it results in severe anemia also. So he wants an amputation. Okay, the doctors have actually said that it's too risky, we cannot operate. So we are not able to operate. So it's like there would be a point of no return for this patient. But this 20-year-old boy says that no, I want an amputation because I think that if my leg is cut, if this tumor is cut, everything will become normal. So what are you going to suggest to this patient? What is your next step here? Any responses? Okay. So, yeah, I think there's something in the chat box.
Yes, ma'am. Dr. Ravindra says counseling and explanation. Dr.
Okay.
Dilip says evaluate the options and explain.
Okay. So, yeah, so I am okay. So tell him that risk is more than benefit. Speak to nearest relatives. Okay. What else? Anything else? Okay. So this is a dilemma again between doing good and then avoiding harm also, right? So we want to avoid the harm uh, by refusing the amputation. Okay. And we also want to do good. So the dilemma between these two principles are actually stopping us from, going ahead with the operation. But then also the patient autonomy has now taken a, third shift. Like you can actually say there is a dilemma between patient autonomy and beneficence and non-beneficence. So there'll be three things, coming in conflict with each other. So what do we do next? We actually think, what are the chances of cure? This is for us to understand what are his chances of cure. Okay. Is the survival of the patient likely after he gets a amputation done? Will the amputation, if he survives also, will the amputation improve his condition? I mean, is it really going to reverse the lung metastasis for that reason. Just a second. So, is this amputation going to improve his condition? Then maybe when we think about all this particular picture or for this particular patient, our questions will be answered. Now, somebody said in the chat box that, explain and talk to the relatives. Now, I want to know, why would you want to involve the relatives here? I'm not saying it is wrong. I just want to understand the, why are you involving the relatives out here?
Ma'am, the relatives are the closest possible, so more trust will be there. Plus, they are older than him in age, so they might understand his condition and see that the harm can be avoided. If we can prolong his life to some extent, also reduce his suffering in other ways possible rather than operating.
Okay, but if that is not possible, are you sure that, any other way would actually, in this particular scenario, any other way that we take might actually improve his condition, or, the whole course of the disease would be different?
See if other modalities of cancer treatment can be useful without subjecting him to amputation, like radiation therapy or chemotherapy in this case.
Okay. So that's what I'm asking. Are you sure that the other modalities would work for this patient? The patient,
In this scenario, we not being the specialist doctors, the decision would lie in the hands of oncologist or orthopedician.
but then the oncologist would always, tell you that there would be a modality to actually improve the condition of the patient. Have you worked in cancer before?
No, ma'am.
Okay. All right. So people who are working in cancer might agree with me that this particular stage is the last stage of the patient. So as to say, it's stage 4. And stage 4 with multiple metastasis, severe anemia, basically with, osteosarcoma, patients may not actually survive for a longer period of time. And lung metastasis, multiple lung metastasis, will have its own toll on the patient, might actually go into severe breathlessness at one point of time, okay, where radiation therapy and other, cancer treatments like chemotherapy may not be feasible for the patient, okay. So this is basically an oncological scenario where I wanted to point out, the dilemma. So this is a dilemma that you have just now actually explained to us. And here also, you will have, it's a very good thing that you would actually consult the oncologist and the orthopedician to give you a certain guideline about how to proceed for this patient. But then uh, we are talking about an end of life situation for this particular patient, and that is where, your decisions would actually matter a lot, because the orthopedician and the oncologist would actually give you the same possibilities, the same percentage of, because when the patient is actually wanting to have a surgery, an amputation, and his own conscience is actually telling him that if I get this thing out of my body by cutting my leg, I will become better. So that is the question where you have to intervene. That is where you have to actually tell him, if you tell the relatives, you are actually eh, giving the information via somebody else. So it might be a worthwhile situation to actually directly sit with the patient, because it's already 20 years, you know. He knows his suffering much better than anybody else. So it will be very, very valuable if you actually start your conversations one to one with this particular patient. Okay. You can actually take the relatives one after another, because they might not they might not add value to what you are, the kind of advice that you'll be giving. They might actually add much to the agony by sitting and crying in front of the patient. Okay. I hope you agree with me, because that is what the situation is like. Because if you call an elder brother, he might actually want um, not to disclose anything. Okay. If you take the help of the father or the mother, they may not be able to take that particular, uh, uh, what to say, that particular communication. They may not want to be there. All right. They are not able to face it. Okay. Because for them, a 20-year-old boy is a kid only. For them, it's their child only. So there are certain dynamics that you'll have to understand. You'll have to weigh the situation. And it's always better to talk directly uh, to the patient. Uh, Even I have even seen small kids actually wanting to know what has happened to them, and taking information out of the doctor. Okay. So that this situation, your explanations to not going for the amputation, and maybe trying to pacify the patient regarding complete palliative care or pain management or symptomatic control, and of course giving them a certain futuristic roadmap of what is going to happen next, is the right way to manage this situation. There is something in the chat box, I think. Patient may not be in the right state of mind psychologically to understand the situation. That's why the closest possible relatives who understand and accepted the situation. I do agree with you, madam. But what I wanted to point out here is that, if this particular patient is able to tell you that I want this particular leg to be removed, I would actually want to assume that the patient is psychologically in the right state of mind, because he's actually giving us a decision. And if we think that he is not psychologically mindful about what is going on, he may not be actually wanting to take any kind of treatment at all. There would be signs and symptoms of withdrawal from that particular stage. He may not be wanting to talk to anybody. He might be depressed. He might be in a state of anxiety. So if I say that in this particular scenario where this patient wants an amputation, I would want to assume that the patient is actually in the right state of mind, is not compromised psychologically. Am I able to convince you, madam? Dr. Kalyani?
Yes,
She's
ma'am.
saying yes, ma'am.
Okay. Thank you. That saves me a lot from some other explanations also. Okay, so we'll just go on to the other slides. Yeah. So again, when we were talking about the relatives, so this another patient, if there is another patient of the same age with advanced cancer, okay, say this particular cancer with in an advanced stage, where when we talk about advanced cancer, it's actually spread to other parts, and it's stage 4. So the relatives have insisted that issues of diagnosis and prognosis should not be discussed with the patient. Okay. Now, when you go in your rounds to see him, he is alone. Okay. And he asks you what is wrong with him. So, what will you tell him? And what is the dilemma here? Something in the chat.
So Dr. Lorna is saying, ask him what he knows.
Okay.
The patient is no longer a minor, so he has a right to information.
Absolutely.
We should tell him about the diagnosis.
Okay.
Discuss with patient what he knows about his condition.
Right. So basically, uh, so I am the patient. I am 20-year-old. I I have this advanced cancer. I really don't know what is happening to me. Okay. So I'm asking you, madam, what has happened to me? So what is the next step that you'll take? Can you just give me a small framework of how are you going to do that? You just cannot actually, uh, go and quarrel with the relatives that he is 20-year-old. He has the right to know. So, how is it like going to be? We are going to be in a big soup if we do that, isn't it? We are going to,
Doctor.
yeah, ma'am. Yes.
Yeah. So Dr. Dilip says, but we need to respect the family decision also. Can we say we'll discuss together with you and your family, explain step by step, discuss what he has gone through, his symptoms, his treatment, then inform the relatives that he is aware of what's happening to him. So in a controlled manner, disclose the diagnosis with relatives. And Dr. Lorna says, have a meeting with the relatives.
Yes, I would actually, everything is correct. All explanations that all the responses are actually correct. But then, okay, so there's another message. Find out what their concerns are, right? So let us understand one simple fact. I have a 20-year-old son. My son is actually 20 years old. He's an adult, but for me, he's still the 5-year-old kid. Okay. I am absolutely protective about him. He has recently bought a bike, which we were really worried about. And he goes to his college, he does his job, he comes back, and till he is, inside the house at the end of the day, there'd be something inside my mind, inside my heart, that would be actually a little anxiety, filled with anxiety. Is he okay? Has he driven a little more? Is has he been encountering some kind of problems? So I have a mind of a parent, and the parent inside me is always protective about the child. All right. So similar here, we have to respect the point that these relatives are always being protective about this 20-year-old kid. Okay. So the best part is definitely at this point of time, when you are there and you find the patient is alone, he takes this opportunity to ask you that what is wrong with him. You just cannot actually disclose everything then and there. You have to manage the situation like, okay, I understand. I still have, been waiting for some more reports to come in. You can actually give him an example of some blood report, and then tell him that, so let me see this report and then talk to you. Would you mind if I also discuss this with your parents or your relatives? And there might be two responses. He might actually say, yeah, okay, fine. Let them also come, then we'll discuss. Or the other response might be, no. If they are there, they will not let you talk to me at all. So I want you to talk to me. Okay. So these two situations would be two different situations, two different things. If he says that, okay, let my parents come, but I will also need to be there when you discuss, your work is half done. And if he says, no, if they are there, they will not allow me to talk to you, then you have a different situation. So there will be another step involved in the second situation, where you will have to first talk to the relatives. You'll have to first explain everything to them, that it's his body, he has the right to know. He is an individual, and uh, you know it might be that he knows everything from before. It's only that he's wanting the doctor or uh, the the person who has been taking care of him from the medical point of view, is wanting his diagnosis to be disclosed to him. Okay, so two situations can happen, and both of these situations might have an extra step of, information sharing or counseling being done on a different together. So the basic thing is to, at that point of time, not tell him what is wrong with him, but then buy some time from him. Okay, telling him that, either we talk together, or maybe I can talk to your parents first, find out why they're not, wanting you to be in the meeting. And I would really want them, try to convince them that they have to allow everything to be discussed along with you. So these two different situations will have two different approaches. And I'm sure, in your communication classes, communication skill classes, you will have such situations where we generally term these things as collusion, where the relatives do not really want their patients to know what is wrong with them. Okay, so how do we manage collusion? This is a peculiar case of handling collusion. But then if you can handle collusion, many things will actually fall into place. There might be instances where the relatives have actually abandoned you. They would say that, no, this doctor is of no good. We'll actually go to another one. I have sincerely faced these kind of situations also, where they have left you also. So we should not be, actually going to that particular extent where the relatives decide that they have to leave this doctor. Okay, because once they leave, the patient is out of your hands, and you will never come to know what has happened to this patient. You wanted to do good, but you ended up doing harm to this patient. Okay.
There are few comments in the chat.
Okay, yeah.
So, Dr. Ravindra says most of the palliative care patients are not aware of the diagnosis and prognosis, and it is always kept as a secret. Yeah, I think that was what you are talking about. And
Yes.
Dr. Kalyani says some patients Google their condition and already know the diagnosis. What if it is a direct question? Do I have cancer? For example, if the patient asks you directly, do I have cancer? How would you handle that? I think, Dr. Kalyani, there is a session which is upcoming the next week where communication will be dealt with the part one and part two. So, part two of communication is completely based on the collusion as well as breaking bad news, where you will be learning it in detail.
Yes, absolutely. Okay, somebody's raised their hand also.
Yes, Dr. Kurt, please go ahead.
Yeah, good afternoon. So I have a case currently where I have an 8-year-old child who's had his second relapse of ALL. And the oncologist has said as of now, nothing
Yeah,
more can be done. So the parents are adamant. First, when it comes to counseling, the father will not let the mother or the child attend the counseling. And then so we do not know exactly what the father conveys to the mother. But from my understanding, the mother is aware that the child is terminal. But the parents insist that the child not know that he has cancer again. But being this child is an 8-year-old, so he's a minor. And my second thing is that he has gone through this twice because this is his second relapse. So he knows the symptoms and everything. But he is insistent that he does not want to go to the hospital anymore. So the child wants to know what is happening to him, but the parents say no. But I'm like, my thing is the child's a minor and has gone through this before. So how would I approach it?
this is a very, very common situation where children are actually subjected to these kind of things. But, my sincere advice is that you have to talk to the father at length. Okay. uh, please give as much as of your time to the father, trying to find out, because as I said, we are all protective. The father is trying to be protective, but also let him know that much of protection might actually end up in hurting them more, because it's a kind of a conspiracy of the darkness.
Correct.
Both the mother and the child are in the dark. Okay.
Correct.
But having said this, the uh, you have to tell them, you have to cite examples that, I have seen such patients. I have had situations where the child actually, remembers what has happened when I first went for my chemotherapies,
Correct.
how hurtful it was. Okay. And I am again going through the same road. Why
Correct.
is my father wanting to do that? So they will, I'm sure, you would be having, child counselors. I don't know whether you
Correct.
have or not, but
We-
if you
we-
have, please take help of those counselors.
okay.
I'm sure they are also, trained in cancer care. Uh,
But as a minor, does the minor have a right to know
of
if he's gone
course,
through it before?
definitely, because they will have their own ways of expressing pain.
Okay.
you know they will have, we just cannot shrug it off our shoulders that okay, he's a minor, he may not have, the right to autonomy doesn't, apply to minors. It's not like that. These are ethical principles, are universally same to all. It
Okay.
is our, the onus is on us. How do we communicate these things to them? Okay. If
Yes.
you think that you are not the right person to convey this to the child, let the patient be handled by somebody who's more trained to do that.
Yes.
Take help of people who, see, nowadays it's like it's a virtual world. And why not take the help of a pediatric oncologist, pediatric palliative care specialist who have been handling such patients?
Correct.
And, if you know Dr. Gayatri Palat from Hyderabad, she's internationally acclaimed pediatric palliative care physician. You can always approach her. I'm sure Hashmat has her number. You can actually approach her and take the help, take their team's help to actually get access to this patient. I mean, this is an extremely dicey situation that you are facing, and I salute you because you are actually taking care of such patients. But my sincere advice at this point of time would be to talk to the father at length, try to find out what why he is acting like that, or what are his concerns. It might be so that he needs to open up a lot. He might as well want to get rid of the baggage that he has been carrying. I'm sure as a male, he has never cried over, this situation that he's handling so much. He's trying to, maybe handle his wife. He's trying to handle the kid. He's trying to handle the finances of the family. So his plate is already full with so many things. So he might as well need a break of all this, and you might be the best person to shed the load of this particular person. And my heart actually goes on out to the father, because he's been handling it quite alone, and he's unable to cry, he's unable to talk to the wife, he's unable to share with anybody. So it might be worthwhile to actually give some bit of time to the father, talk to him, use your touch if needed. That might actually work for him.
Thank you, doctor.
Yeah, let him cry as much as possible, and after everything opens up, he might actually get a clear road of where to go. Does that help a little?
Yes. Thank you so much. Yes. Thank you so much.
Okay.
Okay, ma'am, I think we can go ahead because we are short of time. And then once ma'am completes her, didactic, then we can take up the remaining questions.
Yes, right. No. Okay. Right. So exactly. So this dilemma is like the question of, is it right to deliberately mislead a person or to withhold information that a person is asking for at the insistence of the patient's relatives? So this is a situation that we are facing with that particular patient. Now, there are some clinical scenarios also. For example, this is a 50-year-old lady with cancer of the stomach and has come to the hospital in a terminal stage. When I say terminal state, that means she has very few hours to live, perhaps. And you see that clinically her systolic BP is 50. She's extremely restless. Now, will you give her parenteral midazolam, which might actually hasten death? So this is particularly for those palliative care physicians who are actually totally into end of life care, because we use midazolam. Parenteral midazolam is the gold standard of relieving terminal restlessness. Okay. Now, there are certain questions here that you will need to understand. First is that you have to know the art of prognostication in a terminal situation. You have to know by means of your experience, whether this person is going to live for another few hours, or maybe, another few days, or another few weeks. So prognostication is the key to handle such situations. And being in palliative care, if you are a seasoned palliative care doctor, palliative care physician, or even a nurse, you will actually appreciate the signs and symptoms where you might as well prognosticate that yes, this patient may not be living for another few hours. And that is where terminal restlessness, agitation, all these things might surface up. So in terminal restlessness, we in order to relieve the patient of restlessness, we use parenteral midazolam. But the question is that comes from basically from your colleagues, in the emergency room, or your oncologist colleagues, or your colleagues in neurology, nephrology.
Ma'am, Gayatri, can you hear me?
Yes, ma'am.
You cannot hear Dr. Sanghamitra, right?
She's on mute.
Okay.
I guess the system is hanged.
Yes, I think she will be joining back. Maybe we can wait for a few minutes. I hope she had some technical glitch. Participants, we are waiting for Dr. Sanghamitra to rejoin. Gayatri, meanwhile, you can pause the recording for some time, and once she joins back, you can start recording once again.
Okay.
Sorry about this. Can you please turn on the sharing tab?
Yes, ma'am.
It's not turned on.
1 second, ma'am. Can I share that PPT from my side?
Yeah, you can.
Okay.
Can you please go to the slide where I left?
Yeah.
That's the principle of double effect. Yeah, principle of double effect. Next. Yes, that's the one. Yeah. Yeah, so this the principle of double effect actually says that a single act having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Now, let me give you an example to explain this. So we all use morphine to take care of the pain of our patients. Okay. Now, morphine has two effects, two possible foreseen effects. One is pain management. It takes care of extreme pain. And second one might be, possible nausea or constipation or itching. Okay. Now we know that if we give morphine to our patient, the patient will be relieved of our pain. Okay. That is a good effect of morphine. But we are aware that morphine will cause constipation. Morphine will also cause nausea for this patient. Okay. We know that is a little harmful for this patient. But we are using morphine to take care of the pain of this patient, and we are actually not intending to induce constipation or induce nausea for this patient. Okay, so this is where, in the previous slide, where we were talking about these patients using midazolam for this patient. Okay, we know that use of midazolam is definitely going to relieve the patient of terminal restlessness. But we also know that use of midazolam might inadvertently hasten this patient's death. Okay, that is a harmful effect. But we are not intending to induce death to this patient. Our intention is to relieve the patient of restlessness, terminal restlessness, which is extremely painful for terminal patients. And that is where, in ICUs, you see that the patient is restrained. The patient is extremely restless. Patient is perhaps going to die in another 6 to 7 hours, and the patient is restrained. We tie the patient's hands and legs and everything. Okay, and that situation is extremely painful for the medical staff also, because as young doctors, when we intern in the ICUs and we see patients being restrained, it instills a lot of fear inside us. Perhaps we would actually come out of the ICU and we tell our friends that, I won't want to die like this. I won't allow my father or my mother to be inside the ICU for any reason, because we know that, at such kind of a situation, they might have to be restrained. But there is a possible answer to take care of such situations. And in terminal patients, for terminal restlessness, we use in intravenous midazolam. Okay, so next slide please. So this is another dilemma where, when I was talking about the ICU situation, so this particular patient is a 74-year-old gentleman. He has an advanced cancer of the lung. He has completed a course of radiotherapy. He has completed a course of chemotherapy. And then, he's brought to the casualty with a feeble pulse, 60 millimeter of systolic BP. He's in a drowsy kind of a situation, an altered breathing pattern. and the family is, quite rich. Family wants everything to be done. Now, what do we do in such a situation? Do we actually resuscitate this patient and shift him to the ICU? Do we keep on investigating what is happening, what might be the possible answers, what might be the parameters, do we decide on giving him a hemodynamic and ventilatory support? Do we think about hydration and nutrition? So these are ethical dilemmas where we need to understand the the future of this particular patient. Whatever we do, the patient is absolutely. So Dr. Kurt has actually mentioned that, see, if the patient has made an arrangement for advanced directives. I'm so glad that you have come up with this particular point, because advanced directives are, nowadays it's being implemented in all hospitals. Okay, there are committees that have been formed, but this also puts us in a dilemma whether to, go according to the family's wishes. If there is an advance directive being made, I think we don't need to really answer the questions in this particular slide. But if there are no advance directives, which is, in 70% of the cases still in India, in smaller cities and in nursing homes where people have the money and they want to save, want to give everything to their patient. They want to subject the patient to everything, even when they know that such kind of situation may not actually give a proper, a good outcome for such a patient. Okay, so how do we handle such situations? How do we handle such dilemmas? How do we handle the relatives? So it's all communication skills. Yeah. Next slide. So this brings us to what kind of treatment do we offer if we do not offer this patient hemodynamic support, if we do not offer this patient ICU support, if we do not offer this patient any kind of other curative therapies. What generally do we offer? So we offer the appropriate kind of treatment which is relevant for this patient at this particular stage of his life. Okay, we are not denying him of anything that might give him some relief. Okay, what we are trying to do is that we are not trying to give him anything which is not going to give him any benefit. So appropriate treatment for this patient means that it is that treatment that does not provide net benefit to the patient, may ethically and legally be withdrawn, and the goal of medicine should shift to the palliation of symptoms. Okay, that means that if we, for this particular patient, this is a 74-year-old gentleman, and has taken all sort of chemotherapy and radiotherapies, completed everything, still in the advanced stage, and perhaps going to die within next few hours, any kind of treatment that we do should actually constitute the appropriate kind of a treatment, and basically to palliate the symptoms that are that we are actually seeing. Next. So the appropriate treatment points should be, in and around the patient's biological prospects, the therapeutic aim and benefits of each treatment that we aim to give. If there is a, if we aim to give him, IV normal saline, what is the benefit for this patient? If we try to give him oxygen, what is the benefit? Okay, so we need to see the therapeutic aim and benefit of each of such steps that we take, the adverse effects taken into account for each of such treatments, and the need of not to prescribe a lingering death. Kindly bear the fourth point in mind always. We must not prescribe a lingering death to this patient. When we actually shift this patient to the ICU, restrain him during the terminal hours of restlessness, we are prescribing this patient a lingering death. Next slide. So this brings us to the last but not the least, the most important principle, and that is the principle of justice. And the principle of justice says that we have to balance the needs of the individual with the needs of the society. Next. So taking this particular patient into consideration, Mr. SS, who is a 86-year-old journalist, he was he has a lot of accomplishments like a thinker, a writer. He has had lung cancer. The cancer had spread to the spine, the ribs, and sacrum. He has actually taken care of his psychiatric son. He has 6 grandchildren. The family actually knows about the goals of the care, being pain management and finding out the family finances. He wants to do the Janevu Sanskar of 3 grandsons. So everything actually, he is actually taken care of so many things. He's seen his life all the time. Now the situation is that his breathless has been increasing. Okay, because of the cancer, because of the lung cancer, his breathlessness is increasing. Now, do we actually shift this patient to the ICU? If we have a bed in the ICU, the family wants to do that, but do we shift that patient? Okay, next please. So, okay, so if we are thinking about ICU admission, does that mean we are generally, are we not actually taking the chance of a younger patient who might be needing an ICU admission? For example, this particular 86-year-old gentleman is waiting for an ICU bed, and all of a sudden in the emergency there is another patient who is a 20-year-old boy, just had a head injury in the road traffic accident and needs an immediate ICU admission. Would you not actually give that bed to this patient? Okay, so this particular situation also demands a lot of pros and cons to be looked after, to counsel the family of this patient, to talk to the family of the patient about what might be the benefits of ICU admission. Are we actually going to save their 86-year-old father for another 6 years? Or are we actually going to save the 20-year-old road traffic accident head injury patient? Okay, next please. Next. Yeah, so so if for some reason we are allocating this particular resource to this 86-year-old gentleman, will it be a fair utilization of the family's resources, or the allocation of hospital resources and of the society, etc.? Yeah, next please. So that brings us to the broader question of euthanasia. I mean, should we euthanize such patients who are actually going to die? Okay, So basically, let us understand that euthanasia is an act or procedure in which someone takes active means such as a lethal injection to bring about someone's death, and allowing natural deaths, which definitely involves withholding or withdrawing a futile treatment, is not amounting to euthanasia at all. Okay, we are allowing natural deaths to occur, and that does not amount to euthanasia at all.
Ma'am,
Yeah.
just to tell you that the time is 3:32 as of now.
Yeah,
So just, yeah,
I'll take
so,
another 5 minutes.
okay, ma'am.
Can
Okay.
you allow me that?
Yes, ma'am. Yes,
Yeah,
ma'am.
because we haven't touched euthanasia at all. Okay. Yeah.
Okay, okay.
So, so euthanasia is legal in Netherlands, Belgium, and Luxembourg, but it is absolutely illegal in India and many other countries for this particular reason, that we have to allow natural deaths to occur. Okay, and by promoting euthanasia, where we are actively bringing about somebody's death, it is amounting to murder. It is nothing else. Okay, even if we are aiming to relieve the patient of his sufferings, we are murdering somebody. We are bringing about a death which is unnatural, by means of a lethal injection or whatever means. Okay, so this is absolutely illegal, and there is no situation where my conscience, or for that reason any doctor's conscience will allow this. All right, next please. So we'll skip all this. Yeah, next. So why do doctors generally go for futile treatment? The question is, if we cannot euthanize, then we have to keep on treating. Is this the justification for futile treatment? Next, please. So physicians are basically oriented to curative treatment. Physicians do not really have any training in palliative care, which gives us the essence of pain relief and relief of suffering. And there is always a fear of being blamed for suboptimal treatment, because if you tell the family members that right now we cannot do anything or nothing is going to work, that family will be bound to think that, okay, so this doctor doesn't know anything. We will have to go to a doctor who's a super specialist. Okay. So there is always a pressure on physicians to give something or the other. All right. Whether it is a small injection or whether it is a oxygen, whether it is a huge treatment, whether it is a long list of things, the physicians are actually always inside a fear of being blamed for suboptimal treatment. Okay. And then definitely the ignorance about the guidelines for end of life care. We really, until I entered into palliative care, I never knew there would be any guidelines for taking care of the people who are at their end of life. Next, please. So kindly go through this particular paper, which is in the Indian Journal of Critical Care Medicine and also in the Indian Journal of Palliative Care. This is the end of life care policy, and they have described a 15-step guideline for taking care of the end of people at end of life care, and you will get proper guidelines about how to implement end-of-life care in your institution, in your setup. Next, please. Next. So basically, euthanasia is a deliberate intervention which is undertaken with the expressed intention of ending life to relieve the intractable suffering. But when we say a deliberate intervention, we are generally amounting the patient to something called murder. It cannot be giving relief by murdering someone. Okay, next. So basically, this gentleman had talked about advanced directives and of course DNR. Next, please. So using morphine and other drugs to relieve pain does not amount to euthanasia. Stopping the treatment when the burden outweighs the benefits is not euthanasia. Allowing nature to take its course by allowing natural deaths to happen is not euthanasia. Okay, next. So please read this book by Atul Gawande. He has actually given, I'm sure many of you might have actually read this particular book of Being Mortal. So I think we've come to the end of the presentation. There are few slides which may not be of much importance, but I've already shared the presentation with Gayatri and she'll be sharing with you. So I know that I've overshot the time, but still maybe one or two questions.
Yes, participants. So I have actually requested them to post their questions in the chat box, ma'am, so that since we are running short of time, if
I understand.
but we haven't received any till now.
Okay. Anyway, so I think we can just close this down because it's already.
So Dr. Kalyani is asking, can tattoo of DNR be considered legal?
No, I don't think so, Dr. Kalyani, because DNR has different legal aspects in India and abroad. So we have, I think, currently the Supreme Court has also decided on how to write advanced directives and do a DNR. So that is a complete legal thing, and tattoos cannot be considered because tattoos can be made by somebody else also when you are not in your senses. So maybe that cannot be considered. It has to be on a proper legal document signed by the proper legal representatives and the patient party also.
So I
I
have
think,
shared that in the group, the living will and the attorney
yeah.
authorization, which was recently published, which came into practice. So I have shared that document in the group with all of you. I hope that helps, ma'am.
Absolutely, definitely. Absolutely, Dr. Kalyani. So advanced directives, it's just, I think, came out only in January 2023 or something. And it's a big leap as far as end of life care is concerned. I hope when I am in my end of life care, I'll have a good advanced directive for myself. So we have come a long way and we still have to go a long way actually. And I'm sure with so many awareness sessions going on amongst the doctors, the medical fraternity, once they are aware of this, only then it can be properly implemented in hospitals and in setups. So getting our doctors and our medical fraternity into this particular loop is much more important than the common public coming in. So, the public definitely comes in, but before that, the doctors will have to be ready with their knowledge, their part of the knowledge. So, yeah, right.
Yes. Yeah, I think there
Thank
are
you
no
so
more
much.
questions, ma'am. Thank you so much, Sanghamitra ma'am, for joining us
Thank
today.
you so much. Yeah. Thanks.
Thank you. Over to you, Gayatri.
Thank you so much, Dr. Sanghamitra ma'am and Dr. Hashmat ma'am, for the wonderful session. And I hope, as always, the session is enriched with much of knowledge, and I hope you all got much insights about medical ethics. And thank you for all participants for your joining and your time. And we are looking forward to see you in the next session. Thank you all.